Once you've mastered plaques, let's move on to two of the most essential views in the entire echo exam, the RV inflow and the RV outflow. Here's the best part. You don't move the probe at all. Patient position reminder. Your patient remains in left lateral decubitus. The secret to RVIT and RVOT. You do not move the probe. You do not rotate the probe. The only thing you change is the angle. How to get the RV inflow. From plaques, simply angle the probe down towards the patient's right hip. This gives you immediate access to one of the most essential right-sided views. Next, optimize the RV inflow view. In this view, you should be able to see your inferior vena cava, your superior vena cava, your right atrium, your right ventricle, your septal leaflet of the tricuspid valve, and your anterior leaflet of the tricuspid valve, your anterior lateral or free wall, your inferior wall, coronary sinus, or what we call the ostium, and sometimes a eustachian valve. Once this is optimized, acquire this image. Save a 2 to 3 second grayscale cine clip of the RVIT view. Add color Doppler. Place the color box over the entire right atrium and tricuspid valve to capture the full TR jet. Acquire this image. Save a 2 to 3 second cine clip of the color Doppler of the RVIT. Now, place a continuous wave Doppler through the tricuspid valve. This is to capture your essential pulmonary pressure measurement. This step gives you one of the most important numbers in all of echocardiography, the peak TR velocity. 1. Measure only the densest, clearly visible portion of the envelope. You do not measure what you cannot see. If it's big enough, you want to trace the VTI whenever you can see a complete waveform or whenever a complete waveform is present. Acquire this image of the continuous wave Doppler TR jet with the calipers placed. Remember, for tricuspid regurgitation in the RVIT, you will always measure below the baseline. If the tricuspid valve looks abnormal in any way, shape, or form, acquire additional focused images. This means zoom in to make sure that the cardiologist can properly see what you're trying to show them. How to get the RV outflow. From the exact same position, simply angle the probe up towards the patient's left shoulder. This opens another essential right-sided view. Optimize the RVOT view. Visualize the RVOT, the pulmonic valve, and the main pulmonary artery. Acquire this image. Save a 2 to 3 second grayscale clip of the RVOT view. Add color Doppler across the pulmonic valve. Use color Doppler to evaluate forward flow and any pulmonic regurgitation. Acquire this image. Save a 2 to 3 second cine clip of color Doppler across the RVOT. Place a pulse wave Doppler at the RVOT just before you get to the valves to measure 1. the RVOT VTI, 2. the pulmonic acceleration time. This is an essential indicator of pulmonary pressures. Now, some places don't have you do this, but in case they do, you want to follow that protocol. Regardless, you want to make sure you capture the pulse wave Doppler waveform just in case where you work at requires it. Turn on continuous wave Doppler and place it through the pulmonic valve. What this does is it allows you to trace the PV-VTI and notice if pulmonic regurgitation is present. So you're going to measure the end diastolic PI velocity and the pulmonic insufficiency pressure half-time slope. So again, the end diastolic velocity is for pulmonic insufficiency, and the pressure half-time is also for pulmonic insufficiency, but not every place requires both. Typically, one is sufficient. Please remember that pulmonic insufficiency is the same thing as pulmonic regurgitation. Freeze and save a still image of the continuous wave Doppler pulmonic waveform with tracings or calipers. Optional. RVOT diameter. You can measure this as for shunt pathology. They call it a QPQS ratio. You don't need that at this moment. Just know that later on, it is a measurement you might capture. Acquire additional focused images if the pulmonic valve shows abnormalities such as restricted motion, thickened cusps, or significant pulmonic regurgitation. Finally, let's tie this all together. First, congratulations. You've just learned two of the most essential views in the right-sided echo assessment, and you did it without moving the probe even once. Remember, angle down towards the right hip to get your RV inflow or your RVIT view. Angle up towards the left shoulder to get your RV outflow or RVOT view. Necessary acquisitions include three things for both the RVIT and the RVOT. First, capture 2 to 3 second grayscale cine clip for both the RVIT and the RVOT. Second, capture 2 to 3 second color Doppler cine clip for both views. Third, capture a continuous wave Doppler still image showing TR velocity. Finally, capture a continuous wave Doppler still image showing PV, Vmax, and insufficiency. These views and measurements are essential for understanding right-sided pressures, valve function, and overall hemodynamics. If this helped you, subscribe so I can keep helping. Don't miss the next video.